to join. Yes, good evening, ladies and gentlemen. Just give us a minute or so. We're just waiting for some more people to join. Okay, right. It is already 3 minutes past 7. I'm going to start. Good evening. My name is Chris Forster. I'm a chemical pathologist at the Center for Human Metabolomics, and I'll be hosting tonight's presentation by Dr. Tumelo Satekge. Just give me a moment. I just want to quickly introduce him. So Dr. Tumelo Satekge is a chemical pathologist stationed at JDJ Diagnostic. He also has affiliations with the University of Limpopo. He has research interest in pediatric laboratory medicine, inherited metabolic diseases, undiagnosed rare diseases, newborn screening, and medical genetics. He has attended international congresses giving presentations on various facets of pediatric laboratory medicine and inborn errors of metabolism that goes together with several publications in peer-reviewed journals. He completed his Masters of Medicine degree at University of Pretoria. His research was on selective screening for galactosemia in South Africa. He is currently pursuing a PhD in chemical pathology with the study focus on the integration of metabolomics and genomics for inherited metabolic diseases in Limpopo province. Tumelo, welcome, and thank you for presenting. I look forward to your presentation. You're muted.
Thank you so much, Prof. Costa, for the kind introduction. Thank you for inviting me to present on this interesting case. So basically, just want to start by saying that when we talk about rare diseases, we talk about diagnostic odyssey, where it can actually take years to get to a diagnosis. So it can be actually a long and frustrating road to get to a diagnosis. And this was the case for our patient, or our case I'm going to be presenting today with MPS 3 or type 3B. All right, let me start with the case then. So the patient is now 17-year-old male, presented at the age of 4 with a global nodomental delay, with persistent hyperactivity as well as destructive behavior. So he was reported to be normal at birth and was developing well until the age of 4 when the problems started. Family history, he had a brother who had speech delay and also had an uncle with macrocephaly. Otherwise, it was non-significant. So the patients clinically, he had macrocephaly, but there were no other prominent dysmorphic features. And he also noted to have abnormal dental appearance with low oral tone associated with excessive drooling. And neurologically, he had hypotonia as well as hearing impairment. At the age of 6, then he also presented with autistic features, which were manifested as poor eye contact, as well as increasing sensory-seeking behavior or attention behavior, such as biting hard objects, as well as banging objects to make some loud noise. And then cardiac, he had also a mitral and an aortic regurgitation, which complicated with congestive cardiac failure. So they did brain imaging, which showed atrophy of the corpus callosum, as well as the white matter. And then at the age of 9, he was starting to progress, where he had poor weight bearing. He also had significant weight loss, and then was starting to have seizures at that stage. And then when they examined the back, he was found to have significant kyphoscoliosis in the lumbar spine. And they did MRI of the spine, which showed some irregular erosions with thoracic rims and loss of disk space in the lumbar region. So at this point, they assess the patient likely having autosomal spectrum disorder because of the behavioral pattern, as well as rheumatic heart disease because of the mitral and aortic cardiac mitral and aortic regurgitation. And then because of the spinal condition, they also thought it could be having spinal arthritis. And then they did also suspect Fragile X syndrome, which was excluded with common genetic testing. So at the age of 16, that's where now they thought this could be mucopolysaccharidosis. And that's why they did the screening for GAGs and was shown to be elevated. And then the fractionation was done and was found to be to have elevated heparin sulfate. So this was followed by enzyme activity that were for multiplex lysosomal storage diseases. And as you can see, it was found to have a prominently decreased enzyme, the anacetyl alpha glucosinase, which is associated with MPS III. The other enzymes, they were just slightly dropped, maybe because of the degradation of the red blood spot. But what's prominent here is the decreased activity of the enzyme associated with MP3SB. So then genetic testing was done, which then confirmed two variants in the NAGLU gene, which is associated with MP3 or MP type 3B. So this was a missense variant as well as a deleting variant that we picked up, which confirmed a case of MPS 3B, which was diagnosed at the age of 16. So for today will be about MP3 or MPS or mucopolysaccharidosis type 3B, also known as Limpopo syndrome. As an introduction, what are mucopolysaccharidosis? So these are multisystemic lysosomal storage diseases, and then they occur because there's failure of the degradation of the glycosaminoglycans because of enzyme deficiency. So they present as a continual clinical manifestations, whereby you can have the rapid form, which presents early with severe rapid progressing clinical features, as well as the slower and attenuated form, which tend to present later in life and usually associated with milder symptoms. So these are glycosaminoglycans, and this is a complex pathway that is involved in their degradation. Okay, so the main glycosaminoglycans that we get is dimethyl sulfate as well as heparan sulfate. So glycosaminoglycans, so these are repeating modified disaccharides, okay, in which they contain an uronic acid as well as a sulfate. At the beginning, we started with this big molecule complex, which is dimethyl sulfate in this case, as well as the heparan sulfate. And then it undergoes systematic catabolism, okay, where it involves a sulfatase, which removes the sulfates, and then it is followed by a hydrolase, which essentially breaks the glycosidic bond and then removes this part, which then makes the compound smaller and less complex. So this basically repeats itself until you have a single unit there where there is a sulfatase and a hydrolase. So this will be the degradation of the dimethyl sulfate. Okay. So so the common MPS that we see on our settings is MPS type 2, which is actually X-linked. So actually it is the starting enzyme that actually catalyzes both heparin as well as dimethyl sulfate. So interesting, our patient who has MPS 3B has a deficiency of this enzyme, N-acetyl glucosinase. So basically, what happens here as well is that it breaks the glycosidic bond there of the uronic acid, and then it generates the glucosamine there. So what is interesting is that all the MPS type 3, they only manifest with increased heparan sulfate. So basically, they are only involved in the degradation of heparan sulfate. hence it will be elevated in this patient. With regards to MPS type 3, there's 4 subtypes. So the first one is type A, with a deficiency of heparan sulfatase, and then our patient, which has type 2B, deficiency of that enzyme. So it's actually 1 and type 2, they're the ones which are relatively common, with an incidence of 1 in the 100, while type 3 and type 4, we regard them as ultra-rare diseases because they're present in 1 in a million. To focus on MPS IIIB for this patient, so it occurs as a result of pathogenic variant in the NAGLU gene, which is found in the long arm of chromosome 17. So this gene encodes the enzyme N-acetylalpha glucosaminidase, which is found to be deficient, and as a result, you're unable to break down the heparin, and then they accumulate. Okay, so this is the function of the enzyme which I already mentioned, and all these patients, all the types of, except for type 2, they are autosomal recessive, including this one that we see in our patient. So let's look at the pathophysiology. It is so the MPS III, it is the one that's called severe neurological manifestation. So then it is suggested that it's probably the heparan sulfate that contributes to the pathophysiology of this condition. So heparan sulfate is involved in repairing of biology, tissue remodeling, and cellular development, and it plays a big role in the structural support for the glial as well as the neuronal cells, and essential for brain patterning as well as neurogenesis. So therefore, this explains why this patient with MPS III, they have severe neurological manifestation because of this pathophysiology. And actually, it's been shown that increased heparan sulfate in the brain activates focal adhesion and glial cells and glial and neural cells. And this will impair polarization and migration of neurons. And this will also impact the immune signaling, which then release some inflammatory mediators and macrodialysis. And then this is what actually contributes to the neuroinflammation that we see commonly with these patients. And this contributes to the neurodegenerations because the brain generally has an capacity to regenerate. When it comes to clinical manifestations, so I've divided them into ages. So basically, the median age of presentation is age of 4, but they can present earlier, between 1 and 3 years, and usually starts with mild developmental delay, which includes speech and motor. And then from age of 3, then the language and motor delays become more prominent, and then they start to have hyperactivity and aggressive and defiant behaviors. And this behavior becomes very stressful for the mothers because it's really difficult to control because they tend to tantrums, they make a lot of noise, seeking attention, which causes the problem. So they also have sleep disturbances, and then they have frequent upper respiratory tract infections as well as ear infections. And then this is the time where they also start developing some typical cause features, especially in the face, in the skin, as well as it can also affect the hair. And from more than 10 years old, then they start to develop the typical dysmorphic features where they get macrocephaly with a prominent forehead, microglossia, even they can also have bushy eyebrows and so on, other dysmorphic features. And then the neurological symptoms now start to kick in where there's intellectual disability, there's progressive developmental regression, and then it starts to affect mobility. With gait disorders, and then also affects the joints and develop contractures, and then they also develop hearing loss, seizures, and hepatosplenomegaly. But interesting that they don't have liver failure or hypersplenism; they just have enlarged organs, and they can also have umbilical or inguinal hernias, and also present diarrhea and constipation, bouts of constipation and diarrhea. So when they reach the teenage years or early adulthood is where now the disease has progressed, where they have severe dementia with progressive motor disease. And at this point now, they become bedridden or wheelchair bound. So these are just some of the skeletal features that we can appreciate in this patient. So basically, there's these contractures that they get. This one is involved with a small joint, so they could give the appearance of a claw hand because of the thickness and the contractures in the joint. And you can also see that they have hyper-flexible joints as well as some deformity there in the leg. And then they can see also their wrist can also present with wrist drop. So these are some of the skeletal manifestations that can be disruptive for the patient. So there's also this attenuated form. So generally, this one, it tends to progress much slower and tend to present later in life with milder symptoms. So these patients, they can be stable. They have stable intellectual disability for many years. And then because it presents later in adulthood, they tend to, the regression tends to happen later in life. And these patients, then they tend to survive up to adulthood, or more than 30 years. And then because it also presents with late onset, with milder symptoms, often these patients, they're often misdiagnosed or diagnosed late. These other skeletal manifestations. So as you can see, it can affect the spine, like in our patient with the prominent kyphos scoliosis there. It can also result in deformities of the chest, which is the carnetum, and then even these are kind of the skeletal deformities that you can get. Yeah, so you can also see the genome valgum, which is the abnormal appearance there of the knees. This is because of the contractures and the stiffness. So this is some of the things that you need to worry about. And then radiologically, they also give this, if you do a skeletal survey, then they give you this appearance, what they call distal multiplex, which is associated with thickened ribs, kyphoscoliosis, which can confirm on X-ray, and hypoplastic vertebral bodies, thickened diploic space, and as well as hip deformities, which include femoral head osteonecrosis. So some of them you can actually appreciate them there. So basically, it can also give you a clue of making a diagnosis if you're not sure clinically. So, and also imaging of the brain, it has some typical features, which is diffuse cerebral atrophy with enlarged subarachnoid and perivascular spaces. And then the atrophy then results in hypercompensated ventriculomegaly, which has to occupy the cranium. So what you see here, you see some widened cerebral falci, which confirm that this person has cerebral atrophy. And in the spine, they have spinal stenosis or compression, which can result in severe pain in the spinal cord. And then echo, it also shows some typical mitral artery valve thickening or regurgitation mitral valve prolapse. So how do you assess these patients? So clinically, they tend to present with typical features, but obviously you need to have high index of suspicion to be able to suspect it and make a diagnosis. And then if we suspect that this patient may be having MPS, then you can do some screening with glycosaminoglycans concentration or testing. So this is done with dimethylene blue colorimetric assay. And then if they're elevated, then you do some fractionation, which can either be done with electrophoresis or thin layer chromatography. But ideally, the best tool is the LC tandem mass spec. So then you can sort of see which fraction of the GAGs is increased, whether it's heparan sulfate, dermatan sulfate, or the chondroitin sulfate. And then in addition to that, it's also important to do the enzyme activity so that we can see which enzyme is actually low to be able to differentiate a specific type, and then that will be confirmed with molecular testing, which we've seen in our patient. So this is actually the methods how it gets done. So I took this picture when I did my training at CHM about 7 years ago. I did a month-long training there. So this is basically a colorimetric assay, which actually gives some color changes depending on the concentration of the GAG. So basically the dimethyl blue and the GAGs, they form this complex, and then which can be read at a specific, which can generate a specific absorbance, which then will determine whether this patient has elevated GAGs. So as you see here, this is actually the standards, the controls, and the patient samples. So depending on the concentration of the GAGs in the sample, we can get this beautiful color spectrum. Yes. Yeah, okay. And then if it's found to be elevated, we can do the functionation. And the functionation, then do the through the LC tandem mass spec as the preferred one. And then this one was on the Agilent instrument. And this patient actually has MPS type 2. We actually got this from our publication on patient with MPS 2 and severe cardiac lesion. So this actually, the patient has high DS and high heparan sulfate, which then later confirmed to be MPS type 2. So I just want to touch on the molecular aspect of it, of confirming the diagnosis. So there's a scientist, Dr. Patricia Navondo at CHM. So what she did, she did a comprehensive search on the variants that have been reported so far up to, let's say until August. So this was the methodology where she did a literature search through PubMed using the advanced search builder. And then we looked at the original research articles. And then from those articles, we were looking for the variant details in the NAGLU gene, which included the coding, DNA changes, protein changes, transcription excisions if available. And then in parallel, we also do data mining exercise, which was conducted on CleanVar to look for other variants. And then we're interested in the ones which are likely pathogenic, and the ones which are classified as unknown significance. So, and this was the result. So we found 64 variants from the literature, and then most of the other variants that were actually found from the CleanVar database. So what is also interesting is how these variants were classified. 92 were classified as pathogenic, and then 61 as likely pathogenic. Okay. So what is interesting is that they were also quite a big number with uncertainty. So the US, the ones which were variants of unknown significant, and then the ones with conflicting genes were also about 29. So it shows that there's still a lot of uncertainty about these variants, and then probably it will warrant further functional studies. Then Dr. Tumelo, another scientist as well at CHM, what he did was to design a 3D structure of the NAGLU protein or the enzyme. And then after designing the protein, we mapped the variants that were pathogenic or likely pathogenic. Okay, so the ones in red are the ones that have been reported. Have been reported thus far from the search that I've just talked about. So what we see is that we thought maybe the variants will be stationed at the mutational hotspot on the protein, but you can see they're just all over the protein. So which was also something that we sort of didn't expect. So the ones in purple, they are the ones that we detected in this patient. That's the deletion variant as well as the missense one. And then so far they haven't been reported in the literature. So we think they're still novel. As we speak. With regards to genotype-phenotype correlation, so there's this allelic heterogeneity which has been demonstrated with MPS III type 3, and then I would think that's probably related to this allelic heterogeneity contributes to why this patient have a wide clinical spectrum or phenotype, which also explains why they have such a remarkable rate of progression. So there are some that progress quick, and there are ones that progress slowly, which is the attenuated forms. And what's interesting as well is that there are also variants that are known to be associated with milder disease. Okay, and these are the examples of those missense variants. And then there's the variants that are associated with severe forms. So usually these are the ones that are nonsense variants, or the ones with deletion or insertion with a frame shift. So this is the one that causes severe disease. With regards to newborn screening, so because this condition is quite devastating, and so there is some call that probably we should consider newborn screening for MPS, and then we really the advocates for raising awareness for the need for newborn screening, because that newborn screening saves lives with early diagnosis, early detection. And one way of raising awareness for the need of newborn screening is through publications. So these are the publications. The first one is from South Africa, where we sort of report on the history and the current and the future. And for the future, we sort of know which conditions that we should be considered for newborn screening. Okay, so this includes galactosemia, congenital hyperplasia, organic acidemias, propionic acidemia, and total aciduria type 1. So, and then when it comes to Africa, so then newborn sickle cell disease takes a central role because it has been found to be highly prevalent in the sub-Saharan region. But in addition to that, congenital hypothyroidism, it should also be considered, as well as other inborn errors of metabolism, especially in those countries that are still practicing consanguinity. So there's not much evidence to support newborn screening for MPS. First of all, because it tends to progress, it tends to present later in life, into childhood. It's not potentially lethal like the organic acidemias would be in a neonatal period. So probably, and the fact that it's difficult to treat, the cost of enzyme replacement therapy and the eligibility becomes a challenge, as well as the false positive that we can get also from the red blood spot. So probably for MPS, it's not ideal, but then through the Sanofi LSD CLEX, where you can actually screen for a number of lysosomal storage diseases, which also include Pompe and so on. So it can also be useful, but whether it should be implemented in newborns is probably should not be prioritized at this stage. Prognosis, so this patient, usually they survive up to 20 years. Yeah, so the disease tends to progress, and then after reaching early adulthood from 20 years, then they start to struggle, and that's where now the mortality rate becomes increased. So the milder ones, because they progress much slower, they can survive beyond 30 years. And then, so with time, as it progresses, there's decline in the motor function, decline in intellectual disability, and then they lose their basic functional skills and they become dependent. And then most likely they succumb due to neurological regression, dementia, and so. But they can also succumb from other complications from cardiac failure, as well as respiratory complications, particularly upper respiratory tract infection, sort of more of pneumonia, that they can also get aspirate from aspiration because they lose their gag reflex. But this patient, their complications are also managed with operation, so they can also demise from pre and post-operative complications, particularly when it comes to maintaining the airway, because sometimes the airway can be compromised because of the lack of hemoglycans. So our patient, after the initial assessment, he was put on methotrexate, NSAIDs, and prednisone. And then that time, he also had cardiac failure, so they also was put on anti-failure treatment. But despite this treatment, the patient continued to deteriorate neurologically, and then was having excruciating back pain from the kyphoscoliosis that was compressing on the spinal cord. So, and then he eventually had reduced mobility, and then was with abnormal gait, and then became wheelchair bound. And then he also developed subdural hematoma during the course. Suspect was related due to abuse at the special school that he was attending, which then he was eventually taken out. And then he also developed some Raynaud's phenomenon in winter. And he also had mild pancytopenia with epistaxis, which also resulted in the treatment being stopped. So actually, this patient, when he was referred to Polokwane or to Limpopo, it was actually to consider for palliative care. But at that time it was not offered, but then now it is offered, and then genetic counseling was also done. So treatment of these patients, so it really requires a holistic, multidisciplinary approach, okay, with genetic counseling also being being critical as well. So managing them in the childhood, they'll probably require a neurodevelopmental pediatrician. And in adulthood, the neurologist can also see the patient. Psychiatrists also get involved to try to control those behavioral problems. They also develop some eye complications, which need ophthalmologists, cardiac failure, I've already mentioned, and pulmonologists as well to manage the respiratory problems. These patients, they also have quite significant skeletal abnormalities, which require some orthopedic intervention, as well as recurrent ear infections, which can result in hearing impairment, which will need some ENT intervention. So they also require extensive rehab because of that disability that they have, that they get, which includes speech and hearing and physio, as well as occupational therapy. And then I think, it should be complete with the palliative care that is able to also manage the psychological aspect, as well as improving the overall quality of life. And I think I should touch more on the palliative care services, because for MPS III, there is no approved cure. So basically, the treatment is limited to supportive as well as palliative care. And I think referring these patients for palliative care services, it can be really beneficial because patients with rare diseases, they suffer from physical burdens, which include pain, fatigue, neurological issues, psychosocial traumas. And then we know that the prognosis of rare diseases is quite poor among the pediatric patient. So palliative care can be introduced early to improve the quality of life for the patients, as well as their families. And there have been some studies that show that if you introduce palliative care services early, it may actually improve survival and enhance patient satisfaction. But however, in reality, there is a low rate of referral to palliative care, maybe because of lack of awareness, but it's also because there's a lack of specialists or lack of resources to provide this essential service for rare diseases. And the fact that usually these patients, they think of palliative care when it's too late, and I think it really compromises the outcomes, because they don't have enough planning to sort of give the patient the full benefit of palliative care. And then so palliative care needs to be comprehensive, patient-centered throughout their life, so that just to maintain the quality of life throughout this difficult period of dealing with the rare diseases. And I'm proud to say that now in Limpopo, we do have palliative care services. It's in Polokwane, and it's been offered for public and private sector. And then for the pediatric component, it is led by Dr. Malevana, which is actually seeing patients that are less than 13 years. So this patient, actually, we did refer them to palliative care in Limpopo. So when it comes to treatment, usually Alzheimer's rare diseases, they get treated with ERT or enzyme replacement therapy. But for MPS III, it hasn't been beneficial. This is because the ERT does not cross the blood-brain barrier, so it cannot target neurological dysfunction. And this becomes important because MPS type 3, the main problem here is the neurological complications. So, the other thing is that when they did the trial of giving the ERT through the CSF, intracerebral or intrathecal, it showed transient or negligible decrease in the heparan sulfate. So therefore, it was not effective. And because it also has a short half-life, it became unsustainable over a long period of time. And then this ERT is not cheap. It runs into millions. So basically, ERT for MPS III, not recommended. So what is promising is the gene therapy. So there are some trials that look at the adeno-associated virus therapy, which delivers the therapeutic gene into the target cell. So it's recommended because you want to be more specific and relatively safer, and it's got low pathogenicity. And it has the ability to induce lifelong gene expression following even a single administration. And then if you deliver it intrathecally, it will show that it results in significant reduction in the heparan sulfate in the brain. So therefore, it can modify the disease and actually make it better. And other thing that it's able to cross the blood-brain barrier, so meaning that you can actually give it as intravenously. But the problem is that for it to be effective, you need to give it at high dose. And the problem is that if you give, the more higher dose you give, it will increase the cost and also increase the off-target effects, which can also result in some side effects. And the other thing is that you need to be started early, because you need to give it before the patient develops exposure to the adenovirus, because if they develop adenovirus, they develop antibodies, then the antibodies will also act against the gene therapy. It won't be effective there. But it is promising that it could be potentially. So now, as I'm concluding, so these are just other patients. So in Limpopo, we were mainly diagnosing MPS type 2. I think I've diagnosed about 6 patients, all males. Median age of diagnosis is about 6 years. But then what we see now, just this year, we're starting to diagnose other types as well. Like this is another patient that we recently diagnosed with MPS type 6, which was found to be, the enzyme was found to be low. And then this was also confirmed with variant that was found to confirm the diagnosis of type 6. I think it was, it is pathogenic, yeah. So probably it was confirming of the type 6. And the other one is also diagnosed recently, another patient with MPS 3B, also diagnosed this year in Limpopo. So what is also, this also patient was also confirmed with genetic molecular testing. And then I just want to say something about the variant that we picked up. So basically, we picked up this variant classified as pathogenic. It was reported that way. But then this patient, this variant, this deletion variant, it was classified as VUS. But because we have a patient that had this variant before in the Northwest University database. So because of that, they actually they changed the interpretation to likely pathogenic because there was evidence that it was found in another patient with high GAGs as well as low enzyme activity. So, and then it also just happened to be the patient that was presenting, that I'm presenting now, that actually had the same variant. So basically, so our variant, African variant, they tend to be, they are underrepresented in the reference databases, the European one. So basically, it's up to us to sort of start building our own database to be able to interpret these variants to suit our patients, because we think that this VUS that we are seeing, because there's not enough evidence to make them pathogenic, but they probably lead to pathogenic because of the phenotypes and the functional studies that we get exposed to. So I always finalize with what we see in Limpopo. So the common IEMs that we see in Limpopo are galactosemia, congenital hyperplasia due to 21-hydroxylase deficiency, as well as mucopolysaccharidosis. sarcoidosis. So I'm probably now sitting on close to 10. So I think this provides an opportunity for us. So all these patients, they've been confirmed with molecular testing. So now we're actually looking at probably doing some master's studies where they can actually look at the clinical utility of our biomarkers to diagnose this patient, as well as to look at which variants are prevalent in our province. But what is also interesting is that there is a growing conditions that remain undiagnosed. So basically, these are people that are suspected IMDs, but we cannot confirm them because of the limited testing that we have. So even with these patients, actually, we have records of patients that were also suspected of MPS, and come back as negative or inconclusive. So these are the things that we also want to follow up and see if we can get to a diagnosis through the INGWE project. In conclusion, so MPS III type B is one of the common subtypes, and I think we probably start to detect it in South Africa as well. It's progressive. It is with significant mobility and disability. And because there is no cure, I think you must also raise awareness for palliative care services that can really benefit these patients, not only MPS III, but also other rare progressive diseases. So the adeno-associated virus gene therapy, it's holds some promise that could be the potential cure. And just to say that this patient, it took 16 years to go to a diagnosis. And I think if you've been a regular attendee of these webinars, you know about the Ingwe project, whereby we have all these researchers, clinicians, healthcare workers that come together and try to do something about undiagnosed rare diseases. So I think I always refer to that colleagues should just go to the website, take the pledge, and see what we can do so that we can sort of shorten the diagnostic odyssey of patients suffering with rare diseases. All right, so I think that's the end of the presentation. Thank you for the opportunity.
Thank you, Tumelo. Very insightful presentation. To the audience, you're welcome to post your questions in the Q&A. And while we're waiting for the questions to come in, maybe I can ask you one or two things. What's a bit surprising to me is the large number of variants that have been in literature that has been reported as of uncertain significance. I suppose it's surprising and not surprising because, you know, if you think about it, these patients have often got very typical clinical presentations. You have a reduced enzyme activity, which hopefully may be confirmed or whatever, and then you've got a significant increase in heparan sulfate. So you've got so many orthogonal tools that is confirming that can be used to confirm the diagnosis, yet you end up with a variant of unknown significance. So I don't know, do you have thoughts about that?
Yeah, it's interesting. Actually, from the research there, those variants they came from ClinVar, the one that they were transferred as VUS, and there were so many. And so we do know that we'd expect that for the African population because we're underrepresented in the reference databases. So I can only wonder why we would have such a high number. Actually, it also took me by surprise. And where could that be coming from? So I think probably you just have to start investing in functional studies so that you can provide the evidence that these variants probably they are pathogenic. You know, things like in vitro prediction studies, segregation studies, and so on. But I think, yeah, so it's quite surprising, but I think, yeah, we just need the scientists and to come together so that we can do proper functional studies to provide the evidence and so that we can properly classify these variants. But I think they're probably leading towards pathogenicity.
Still, people are really welcome to post your questions. So if you want to be unmuted, just ask. Also, we would love to unmute you. Then you can ask Dr. Satekge yourself. Maybe another question, Tumelo, did you see this patient physically?
Yes, yeah. The patient's following up in Polokwane. We actually did repeat the MRI because there's the severe backache. This backache is becoming severe. So the orthopedics suggested repeat the MRI. Maybe they'll do some intervention.
But did he look like an MPS patient?
Yes, no, he did.
Okay, so coarse facial features and dysostosis multiplex, because it's not always that prominent in the MPS III patients.
Yes, yeah, I think that seeing him now, it fits the clinical picture. The prominent microcephaly, though they've not really typical coarse facial features, but macrocephaly and the skeletal abnormalities were definitely apparent.
Okay.
Yeah. But I think we just have to continue raising awareness so that so we can diagnose them early. Yeah, because so they can bring closure to the families and yeah.
I have a question, if I may.
Yes.
My question is, you said we don't do newborn screening because the disease only presents on a little bit later on. But what if we do diagnose these patients at birth? I know there's no treatment, but is there then a way that you can maybe slow down progression or do more regular testing, or, before things get bad, try to, I don't know, slow it down?
Yeah, so when I say that, probably you should not prioritize it. I'm just thinking about it in our setting related to the other conditions. And that's probably like the one, the acute intoxicating inborn metabolism, those ones which can potentially lethal if you don't pick them up. But definitely there are some in the developed countries. There are some countries that are considering newborn screening for this for LSDs, because it has been shown that especially the ones that they have ERT available, if you start it early, you can definitely prevent the complications and you can actually improve the clinical outcomes. So the problem is that the cost of the ERT, for our setting, not practical because the eligibility, the cost, the availability as well. So, but definitely, if you can perform it, know that it will definitely have some benefit, because I think overall, any rare diseases, the earlier you detect it and you treat, the better the outcomes. So if you have the resources, because remember that also there's the cost of screening on the tender mass spec, which also doesn't come cheap. Yeah. So, but if you have the resources, definitely you should screen. You definitely can improve the outcomes. But for our setting, probably galactosemia, CAH are probably more. Congenital hypothyroidism, we probably should consider them more, because if you have to prioritize.
Okay, and in your opinion, how often do you think doctors miss these cases or misdiagnose them?
Yeah, no, it's always there's a higher chance that they've been missed, and I think platform like this to raise awareness are quite important, because low index of suspicion, lack of awareness, they are most likely been missed, and I think if you have presentation like this where they can raise awareness so that you can sort of have high suspicion and try to refer them early. And I think that's the problem with rare diseases. It's always a challenge to pick them up, and obviously when you miss them, the consequences are dire. We lose the babies, and some succumb to the disease, some have lifelong disabilities, and I think we should prioritize, just more raise the awareness to try to diagnose as many as we can, so that maybe we can make a difference in their lives.
Yeah, I mean, I think the other thing is, MPS patients, they should really be flagged. You may not be able to make the diagnosis, but these patients are morphologically very different from normal individuals. And so when I was a medical student, we would classify an MPS patient as a funny-looking kid, and that would be the end of the process. Hopefully, that doesn't happen anymore. I mean, if you see a patient like this, you either make a diagnosis of MPS or you make a diagnosis of an undiagnosed disease. You may not know about MPS, but you should, this patient should, any of these patients should clearly be flagged as, there is something probably genetically wrong with them, and then at least be channeled appropriately from there, or not sent home with, a note in the file saying funny looking kid. That's what happened. I don't want to give my age away, but some time ago. It definitely shouldn't be happening, so we shouldn't be missing these patients.
But I think what I can say is that, patient with MPS from how, sometimes they can have the typical features that we have to diagnose one and do not miss them again. Especially those ones that have typical features, those specific features, you just have to diagnose one. And I think that's how in Limpopo now we are having so many referrals investigating for these patients, because we diagnose one, and then when you see the next patient, immediately it rings a bell, it flags, like you said, and then they consider the investigations and have been diagnosing. And I think with rare diseases, the formula is it's simple, really. The more you look, or the harder you look, you'll find them. It's that simple. It's just a matter of raising awareness, and then consulting as well, and then and sending the samples, and then get to a diagnosis, hopefully rather earlier than late.
Yeah. I see there's still no questions, so I'll ask you one last question. So, I mean, I think what's quite unique about your case is the fact that the patient's in heart failure. MPS disorders, they often give valve lesions, not those with heparin sulfate so much as actually dermatan sulfate. That's quite prominent in that endomyocardial tissue. But typically these heart lesions are stenosis or regurgitation, but normally they're not clinically significant. It's not one of the clinical difficulties that we have to deal with MPS patients. Now, it seems like your patient has quite severe skeletal manifestations for a MPS III patient. Sounds to me like there's quite severe kyphoscoliosis and pectus carinatum. And I was wondering if the heart failure is perhaps secondary to that rather than due to MPS.
Yeah, interesting. You mentioned that, but they were also suspecting rheumatic heart disease as well. I don't know if they confirmed it.
Okay.
But that also be the underlying thing that could be maybe he had rheumatic heart disease.
Still quite
contribute to CCF.
Okay.
Yeah. So yeah. So and the skeletal abnormalities is also due to dermatan more than heparin.
Yes, yeah. So that's why it seems like it's quite a unique case. With these seems like fairly severe skeletal abnormalities.
Yeah, interesting. You learn every day.
Yeah. I mean, if you had to see him, you saw him clinically now, would you think he's MPS IIIB, or would you rather go for MPS 1 or 2?
Yeah, no, usually
he doesn't have such characteristic facial features, so maybe that would steer you in that direction.
Yeah, it's always difficult because even the refers that you get, usually they will from Limpopo, they will say MPS 2. Maybe because it's the ones that they diagnose commonly, and especially if it's a male, they obviously think. Yeah, but it's also interesting that we are starting to diagnose the other types, like I mentioned in the presentation. So we've been diagnosing type 2s all along. Just this year, we've got other types, which is quite also interesting.
Yeah. Okay, there are no more questions from the audience, I see. Tumelo, thank you very much for your presentation. Just in the interest of the audience, this presentations are sponsored by Sanofi. They, however, have no say in the topics that is selected and also not in the content that we present. So it's purely just enabling us to offer these presentations, at with the level of speakers that we are able to utilize. This is what Sanofi makes possible to us. So I'd like to thank everyone who attended the presentation. Thank you again to Tumelo for presenting. It was a very interesting presentation. I look forward to seeing everybody again next week. I hope you have a wonderful evening and a good week. See you next week, and good night.
Right, Chris, I think we just have to also mention, these tests are actually free for both private and... Yeah. So if you suspect any of these lysosomal storage disorders in your patients, you can refer them to us at the National Metabolomics Platform at the Northwest University, and the test will be done at no charge to the patient, even if it's a state patient, private and state. Sorry, I just wanted to mention that.
Yeah, a very important point.
Important.
Also, currently, we don't have a referral system set up with the NHLS. So the patients from the public sector has been referred to us via some of the private path groups, just because there is no charge. However, we do have a meeting with the NHLS next week. So hopefully in 2026, there will be a referral pathway via the NHLS, which would actually make it very, very easy to diagnose these patients. So hopefully that's something that you could utilize in the future.
Great stuff. Thank you.
Okay, thank you, everyone. Have a great evening.
Right.
Cheers.
Thank you.